I prefer to comment on this latest case posted in Twitter by video because I feel disappointed regarding the diagnosis. The patient, female, 82 years old, diabetic, ischemic heart disease, hypertension, with respiratory failure type 1, as mentioned in the post. And these are the data mentioned in the request. And the pulmonologist requested the HRCT to rule out interstitial lung disease. This is the scenario which I encounter frequently. Because of the clinical data, radiologist has to be guided, but not to be led. In HRCT here, in the beginning, there is 4 cardiac chamber enlargements. We have also pulmonary hypertension, dilated main pulmonary artery, and both pulmonary arteries, right and left. Do we have here features of fibrosing lung disease? By close observation, you can appreciate the presence of significant and dominating interlobular smooth septal thickening and bronchovascular interstitial thickening as well, not traction bronchiectasis. The bronchi are tapering along their course. Only there is peribronchovascular interstitial thickening. And later on in the lung parenchyma, you can appreciate presence of the interlobular septal thickening. Some of the lobules shows ground glass, and the bounding of the pulmonary lobule with the interlobular septa will give the crazy paving appearance. As you can see here, the secondary pulmonary lobules shows ground glass opacity, but they are bounded already by interlobular septal thickening. But there are another interlobular septal thickening smooth elsewhere. So the dominating feature is not the crazy paving, it's the interlobular septal thickening. Some of the areas of the lung shows ground glass opacity, and because of the presence of the interlobular septal thickening, it appears like crazy paving. But the dominating feature is the interlobular smooth thickening. Seems that interlobular septal thickening as a finding is underestimated, and this is the reason of overlooked pulmonary edema, particularly if the request guides the radiologist to think of interstitial lung disease. And although the patient has already obvious gross cardiomegaly, the interlobular septa, if not taken with consideration and appreciated to its significance, that it expresses pulmonary venous congestion within the interlobular septa, causing the thickening because of the congestive heart failure. And it is the second phase of pulmonary venous hypertension. First step is congested pulmonary veins. Second step, interlobular septal thickening. Later on, alveolar pulmonary edema, which started here by the crazy paving and ground glass opacities. So we don't have here interstitial lung disease. NSIP should be present at the periphery with bronchocentric distribution. But here we see that it is geographic. The ground glass is geographic in distribution, not peripheral and bronchocentric. And the dominating feature again is the interlobular septal thickening. I posted already the coronal because the coronal is nicely, and I mentioned this in the late video lecture I posted in YouTube about the reticular opacities in case of interstitial pulmonary edema. That coronal scan is helpful to show nicely the interlobular septal thickening, as you can appreciate here, nicely seen, very obvious. It draws the pulmonary lobules and it gives the complete architecture of the lung, which happens only in case of interlobular septal thickening. And the interlobular septa are smoothly thickened. They are not irregular. The pulmonary lobules are preserved in shape and volume. Some of them, as you can see, are bounding the lobules with ground glass opacity. This is the crazy paving. Elsewhere, and which is more in the scan, is the interlobular septal thickening, which indicates interstitial pulmonary edema and ongoing alveolar pulmonary edema, although of absence of pleural effusion, and patient, if overlooked, as it happens frequently, will pass into the alveolar pulmonary edema. Then patient will be diagnosed in ICU. But if diagnosed in this stage, this can be life-saving for the patient and reduce the hazard that can happen from the phase 3 of pulmonary edema. Last thing, regarding respiratory failure type 1, the pulmonary edema is one of the causes of the type 1 respiratory failure, beside pneumonia, ARDS, pulmonary fibrosis, pulmonary embolism. So it's also, according to the clinical information, interstitial pulmonary edema and ongoing alveolar pulmonary edema is not against, but it is matching the clinical information as well. Thank you for your attention.